Welcome to the Rural American Surgeon. I'm your host, Dr. Randy Lehman, a general surgeon from Indiana. This show is tailored around the nuts and bolts of rural general surgery practice. You will find topics such as practical surgical tips, rural lifestyle, finance, training, practice models, and more. We have a segment called Classic Rural Surgery Stories, where you'll get a feel for how practice in the country differs from the city. If rural surgery is your passion, this show is for you. So, now that the ChloraPrep has dried, let's make our incision. Welcome back, listener, to the Rural American Surgeon Podcast. I'm so honored today to have my guest, Dave Kermode from Iowa, who has been a podcast guest on the Really Rural Surgery podcast several times. And I'm so pleased to have met you at the North American Rural Surgical Society. Dave, thanks for joining us.
Well, thanks for inviting me.
Yeah, so let's dive into a little bit of background about you. Can you just tell us about your training, your background, your practice in rural surgery, what you've done and are doing now?
Ooh, okay. Went to undergrad in Missouri, went to medical school. I'm an osteopath. I went to medical school at Kirksville. Did that on a Navy scholarship, then went into the Navy. I went to medical school to be a full spectrum family medicine physician. Did my first year in the Navy, post medical school as an intern at Naval Hospital Jacksonville in the family medicine program. Fell in love with surgery during that, and so then wanted to do something in surgery. So I had to look for a billet for my GMO tour that was only a year. So because I had talked to a program director that would take me the following year, but he wouldn't guarantee anything after that. So I needed a 1-year slot. The Navy had 3 1-year slots. One was Diego Garcia, one was the USS LaSalle out in the Middle East, and then one was in Antarctica as winter over medical doctor in McMurdo Station. And so fortunately got the McMurdo Station one and went and was a GMO at McMurdo Station, so real remote medicine for a year. After that, did my general surgery residency in Missouri, and then getting out of that, went back to the Navy to fill out the rest of my scholarship in Corpus Christi. Was a general surgeon there and a department head. Then went to practice in a small town in Iowa, and did that for a decade, where I think we had 16 family medicine docs, and then there was an older surgeon and myself. Became just myself for about 6 years. Then the whole critical access hospital thing happened. I was doing a lot of bariatric surgery, and so I had to go to a bigger hospital and joined a practice where there were 4 of us doing bariatrics, and we were for a time the busiest bariatric practice in the state. Then got a call from my medical school and said, "Hey, how would you like to come down and teach?" And also, and I'd always had residents, and mostly primary care residents for my entire career. So this was a chance to teach surgery residents and also teach in medical schools. Did that for 4 years. My wife did not like leaving Iowa, so we came back, and then I've been practicing now. Went back to teaching in a bigger hospital, but always have done some work in a smaller hospital, but kind of combine the two and still do that. I'm getting older. Pretty soon I want to retire.
Understood. So next segment of the show is, why is rural surgery special to you, and why do you keep coming back to it?
I grew up in a town of 8,000. So for me, I think for people like me, we like going to the big city, but after about 3 days, we're like, I got to get back to someplace that's smaller. And just the relationships, when we came back from, she never really left from here, but when we came back from our second stint in Missouri, she basically said, "I'll live here." And she grew up here, was born here, and I'll live anywhere I can see the water tower. So that's pretty much.
That's awesome. That draw home is really powerful. Don't completely understand it. There's definitely country mouse, city mouse dynamics at play, but it's not just any old town. It's her water tower she must have at least some fond memories of her childhood.
Oh no, she had. I mean, her parents are great. I mean,
Yeah.
and the whole and like, well, you know, I never when I talk to my friends that are living in bigger cities and stuff, and like I said, I still practice, you know, part time in a big city, and it's I never worry when I drop my car off to be fixed. It's, you know, I know the right work's going to be done. I'm never going to be overcharged. I go to church with all those guys. It's
Mm-hmm.
like it's you never worry about anything. You go our I probably shouldn't say this over the internet, but our doors are always unlocked. The keys are in the car. It's the whole town's that way.
Yeah, that's exactly the feeling that we have in my small town. And of course, I moved back to the house that I grew up in. You know? So that's where I'm living now. And my wife's from this town too. Now, how far away did you grow up from the place you're now living?
Well, my dad was a Marine, so I grew. I was born in Quantico, Virginia, and then spent most of my early, you know, most of my childhood in California by Camp Pendleton. So,
okay. Well, it's a lot of times that spouse that drives, and then if you got somebody that's from a rural place, might want to be a rural practicing surgeon, and then their spouse ends up being from a city, then that's where you may end up sort of losing a potential rural surgeon as well.
mm-hmm.
Now it's, you know, we're both men, but it's 50-50 now on
Mm-hmm.
men and women, and if it could go either direction, and even it doesn't matter if it's male or female, but you now have a lot of families with two working spouses too. And the other thing that I have heard from several people is this so-and-so person would really like to have this rural practice, but their spouse is a computer engineer or, you know, XYZ job
Mm-hmm.
that generally the job opportunities are better in the city, and they end up going to a city because of that. So it's just interesting, the spouse dynamics that are sort of at play there.
Yeah. I mean, and where we live is definitely driven by my wife. So,
yep. Okay. Well, kudos to her.
But she's great in every different way. She only made one bad mistake in her life. She married me.
Oh, that's marrying you. Yep. That's very predictable. That's beautiful. How long have you been married?
This is our second marriage, but for both of us, the Navy wasn't real kind to marriages with deployments and things. So, so we've been married 23 years.
Okay. Wonderful. All right. Well, today for the How I Do It, we're going to go into extreme detail about a particular operation, as we always do. And today is C-sections from a general surgery perspective. So let me lead in for just a second. I train at Mayo Clinic Rural Surgery track, and I had no idea. How do you know as a resident, you know, what your practice is going to end up being like? But I knew in concept that a rural surgeon is different from a urban surgeon in their scope of practice, in that there are pieces of general surgery that you won't do, like Whipple's, esophagectomy, liver resection. I didn't know about chest cases, but I really don't. Like, I don't do lobectomies. I don't do rectal cases either. I didn't really know that either. But then there's other things that are from typically other specialties that you will do that are more appropriate, which are like those quick, easy, mostly outpatient operations. Patients generally do well, and they should be kept local, and they're pretty straightforward cases. If you have the training, you don't necessarily have to be an orthopedic surgeon to do a carpal tunnel release, for example. And so I didn't know, the problem is in residency, I didn't know with what frequency am I going to see parotids. Okay. Because I mean, I went out of my way to go with the ENTs and do parotids, but there's no parotids. Like, let's be honest, I'm not going to do parotids. It's 1 in 100,000 type of an operation. And it seemed almost equally important to me, all of the different things, whether that's scopes, C-sections, other GYN, such as hysterectomy, oophorectomy, tubal ligation, urology. I was sort of requested to do kidney stones. I spent some extra time going with urology to like learn about that. Then it ended up being kind of a long story, but I don't do them. But I feel pretty comfortable doing it. I used the LithoVue ureteroscope for my choledocoscope. So I mean, it's the same exact thing, but let's not get off on tangent there. And then you go ortho, plastics, ENT, each one of those specialties has these certain things. What I found out when I came out was the things that really increase your value. You talk about like the 80-20 rule, 80% of your value comes from 20% of your activities. Yep. It's scopes and C-sections. Those are the things when you look nationally. Mm-hmm. Now, it might be different for each individual hospital. When you look nationally, the things that will increase your value as a rural surgeon are those two things right now as we sit in the 2020s. And so that's why I'm excited to talk about C-section. And I think there's definitely less and less general surgeons that are comfortable doing it. And there's for a lot of reasons. Maybe we can touch on that. Mm-hmm. But we'll start by talking about the actual technical components. And my first question for you is, are you doing them now? And in other places, how has the practice looked in the past?
I'm not primarily doing them for the last 2 years, and we can get into why that is. But prior to that, I'd done them my entire career, and I've done, I kind of quit counting after about 1,300. So somewhere north of 1,300, probably close to 1,500. So, and then now we back up the primary care docs, fellowship trained primary care docs doing the procedure. And I think, and we can get into why, but I think that's probably the best model given kind of the general situation in the United States with general surgery and C-sections and what the residents feel comfortable doing. Like I say, I'm still working with residents. So,
yeah, but having a backup person doing C-section backup for a family med resident who has done 1,300 in their lifetime is a lot different than having a new grad general surgeon who hasn't done 1,300, didn't do very many in their residency, backing up a family med.
Right. So we're really getting into the weeds here a little bit. But first of all, I'm going to acknowledge right off the bat, my OBGYN colleagues are better at doing this than I am. And that's you have to have that humility going right into it. When we do a C-section, we are what we accuse other doctors of being sometimes, which is a point and shoot sort of proceduralist. I am not making the call, and I never have made the call, and would not feel comfortable making the call. Do you need a C-section? I mean, that person managing that labor is either a family medicine doc or an OBGYN or can be a nurse midwife. And they're the ones that are going to make the call about whether the operation needs to be done. And so that's where I think a lot of the discomfort from residents is. And that's rational because in doing C-sections as a general surgeon, you are, ceding some of your agency. Now, how do you do that in a professional way? That's sort of the conundrum. I thought in this conversation we were getting into technique a little bit more. And
I will.
Yeah, but that's the sort of the philosophically what's going on, and this is something that we all need to talk about. It really is. You're not making the primary decision about whether or not to operate, which is a tough thing. So you really have to have a close relationship with those, I won't say providers, I hate that word, those professionals, those professionals. And professionals are anybody that is primarily taking care of patients. So a PA can be a professional, a nurse practitioner can be a professional, a physician should be a professional. I think every general surgery resident, because in an emergency, in fact, when the first C-section I did as an attending, I did in a state where I didn't have privileges. I was visiting a friend. It went down. It's snowing. The weather's horrible. Can you help? And I said, sure. And then I called the state board the next day. I said, this is what I did. I'm not charging for it. And I don't have a license in your state. And they were very cool about the whole thing. And the outcome was good. So I guess that's the other thing. But everybody has to know how to do it. It's one of those, can you do CPR? We all have to recertify in CPR. I would argue that every general surgeon or every general surgery resident should do 20 or 25 C-sections, just in case you're ever in that position.
Yeah. Okay. Well, maybe let's take a breath and just dive into the details. So the say nurse midwife has been managing the labor and decides that the patient is arrested. What are the most common reasons why they call you and say we now need to do a C-section?
Yeah, great question. And what it is obviously failure to progress with that, despite active management of labor would be the most common indication.
Yeah. And so were you doing elective C-sections?
Yes.
So the elective reasons would be twins, breech.
Yeah, all those would be true, but we were not doing VBACs ever. And I think in a small situation, you should never do a VBAC. It doesn't make any sense. So, and those patients, the nice thing about those patients, if they need a C-section and you know it up front, you can meet them and you can go, it's not an extremis, you're right? Mm-hmm. So you're meeting them beforehand, you're meeting them in the office, you're treating them just like an elective procedure. And it's an elective elective C-section.
Yeah.
It's just a repeat. It's a repeat. So
did you have any rules at your hospital for who could not have an operation there, like BMI over or if they had any comorbidities, preeclampsia?
For most of my practice, we didn't, but there were people that I would say this is unwise to be here. And so that, then that was, so for the repeats, once you get past the third C-section, the chances of bleeding post-procedure and that sort of thing and for complications is much greater. And I think that ought to be done in a setting where you're at a bigger hospital. If there was any, truly crazy things that had happened with the prior C-section or prior C-sections, then you would not want to, you'd want to offload risk as much as possible. I would argue that we shouldn't be doing BMIs greater than 45 or 50. But that hasn't been anything that anybody's bought into, at least.
Yeah, that's been a hard rule. Actually, 50 at several of the critical access hospitals I work at. That's why I was kind of asking. I should also tell the listener that I came out doing C-sections, but then the hospital I was employed at closed the OB department. They were down to about 60 deliveries a year. Post-COVID, couldn't get nurses and made the decision. And I'm super against it because I have an anecdotal story, I guess, about our deliveries and our kids. So when I was a resident at Mayo Clinic, my wife was we had just got married. We got pregnant immediately. She took a job at Olmsted Medical Center, which is an ironic county hospital, like right down the road from the two big Mayo Clinic hospitals, or everybody flies in from Abu Dhabi to go to those hospitals. And then like the Mayo Clinic employees often go over to Olmsted for the anonymity. And anyways, she set up her primary care there and her OB care there. But then, we got further along in her pregnancy, and then she quit working at Olmsted. So our insurance then was no longer made us so that we had to go to Mayo. And we went to Mayo, and in Rochester, you have two options. Either you have a resident or you have a nurse midwife. You can't have an OBGYN, period. So I'm like, okay, well, and I had a rotation set up out in Owatonna. That's 45 minutes west of Rochester, and it's a Mayo Clinic Health System doctors at an Alina hospital, I think it was, or something like that. And out there, they had 3 practicing OBGYNs that shared a traditional, like, here's your doctor practice. And they had call, but if it was like during reasonable hours or they were in town, they would still deliver their own and everything. So I did a rotation out there, and then we liked it, and she set up her OB with them. And then I actually set up my second year OB elective at that time. So I did a few deliveries and then kind of warmed up in a way, and then got to deliver my own daughter while I was on my OB rotation out in Owatonna. But then what happened after that is my daughter set up her primary care out there, and my wife had her OBGYN and primary care out there. And so they would go out there periodically and do things. And then I had a couple minor things that I wanted to see a doctor for. And I ended up driving out to Owatonna to do that, setting up primary care, seeing a specialist out there. And then 2 years later, I was in La Crosse, which is an hour the other direction from Rochester. But we delivered our second child in Owatonna. So, I was waiting for the call, and then I just pieced out and drove all the way over there. And then he set up his primary care, of course. So like we just keep all of our care was then in Owatonna. And then we go back to Indiana, and my wife has to have another operation. And because of the trust, she chose to go 3 states away to get an operation when we lived and I was working in Indiana. To a town of 25,000, critical access hospital with 4 operating rooms in Owatonna, Minnesota. And what happened there is they bought our family by delivering our babies. Mm-hmm. So if a rural hospital can deliver a baby, that's a very generally positive experience. And why do I care so much about working at this hospital across the street from me? It's because I was born there on the 2nd floor. Okay. Saturday, December 3rd, 1988. And they helped bring me into this world. And I just feel like I don't remember that experience, of course, but it matters. And it's just a positive experience that people are going to then associate. And then, of course, the women are generally the healthcare directors of their family. And so when they set up the kids' appointments and they set up appointments for themselves, they drag their husband in for the thing that they have. That is typically how it goes. And if you can make that experience good for that woman, and you can then you buy their family by delivering the baby. Now, I went back to Winnemac and I told this story to the former CEO at the first hospital, the job that I took, and I got a different response. So, a lot of administrators obviously want to shut down the OB department because it loses money. Mm-hmm. Well, you're just not seeing the downstream elective knees and hips and the labs and the imaging and all the ongoing stuff that are going to, like I said, if you buy the family by delivering their babies. And he said, well, that's a great story for you, but most people aren't like you. Most people are in our area that are having babies are Medicaid patients that we're losing money on anyway.
Ooh, cold.
Yeah. And we don't really want to capture those people. Mm. That was kind of the message that I got. Mm-hmm. And it is maybe that's the harsh reality of certain situations, but they have closed the OB department that I was born at. It's a professional goal of mine to get that restarted, but the administration there has told me very clearly it is not our goal to do that. And then there's debates of safety in terms of how many deliveries you need to have per year to have a safe OB department, quality. And there's a lot of different ways to slice it, but it's a increasing challenge. What happens is you lose your OB department, and then 10 years later, you don't have a hospital because you have this slow spiral after that of, you delivered all those babies, you carry on those families for a while, but eventually, like the people around me now, they're not getting the people that are my age are not getting their care in our rural hospitals. Like the people that I know that like go to church with me, for example, they have now delivered their babies down in Lafayette, and now they're very accustomed and used to going to Lafayette, and then they just go down there. That's what we're dealing with.
Yeah, it's a tough thing. So the hospital other than the big hospital in Des Moines, the hospital that I work at most of the time is actually a small hospital right on the border with Missouri, and there's nobody doing OB within 60 miles in any direction. Some places within 120 miles. And so they need to do OB just to maintain, just in case somebody goes into active labor. And every year we have 1 or 2 people that come in like with a cord prolapse or just where they have to be delivered right away. So the place needs to be here, and you probably need a place every 60 miles or so that can do a C-section. And if you think about it, if you're talking about life years saved with a procedure, a C-section is by far where you get the most life years saved. You get a brand new child plus a mom, add those two together, you're looking at maybe 150 years or whatever of life years saved if you intervene in a truly critical situation. So we need better planning. We need we're never going to have apparently a really robust conversation in this country about what healthcare looks like and what it should look like, but hopefully someday we will. But. And then
there's too many challenges. There's challenges you mentioned of the resident being comfortable doing it. Mm-hmm. That's maybe step one. Then there's financial challenges, right? There's perception too. And it's just, it'd be great if, every street corner had a hospital and there's full services, right next door. But how far is too far before it becomes an OB desert? Could we get by with one hospital in every state? A giant hospital in every state. That's obviously the other extreme. And so somewhere in the middle, we're figuring out what is appropriate care.
Yeah, I don't know if we're figuring it out, but I think that conversation is
that's a good point.
It hasn't been had, or nobody can come. So this is one you'll have to edit out probably, but we politically we've reached a point where, and politics is just coming to conclusions about how to solve problems that are acceptable to all parties. And we've gotten to the place where we can't talk to each other and realize that the object is not to win or lose. The object is to come up with an acceptable compromise. And that's where we're at, is we are unwilling to compromise on both sides of the political spectrum. So it's very disheartening.
Yeah. The other issue is 80% of our payers are government payers anyway. We have socialized medicine. It's not like in the view of trying not to be socialized. We've, first off, we let major insurance companies come in that are profit driven, which are even worse. And then now we have in our place, there's Medicare, Medicaid, and then you've got other people that are working for government entities. Mm-hmm. And then you have the VA as well, which I see a fair amount of patients in a non-VA setting now on the Community Connect thing. So you look at everybody, everybody's working for the government. So how that policy changes and drives where the care is delivered, it becomes a big part of it.
Yeah, it's not so much the money as it is the commitment to come up with a comprehensive system, because we do not have a comprehensive system. We have a disjointed, uncoordinated system that does not promote health as it should. That would be my argument.
What's the solution?
Socialism doesn't completely work. The private system doesn't completely work. I don't think anybody knows what the system is. I think that we're large enough that we could experiment in different regions and try to come up with what works best. But it's an ongoing conversation. And the problem is that, I'm a Calvinist. We're all sinners and nothing's going to be perfect until the return of Christ. So it's like, we're trying to do the best we can while we can when we're waiting for the ultimate solution. So the idea that we're going to come up with an ultimate solution is ridiculous.
Yeah, and the point of this podcast is a place for it's a surgeon's lounge for the rural surgeon that doesn't have a bunch of people that they can have this conversation with on a regular basis. And so maybe it's not the point of trying to solve all those problems. Right. It's more or less, what are the resources for that person that is in the trenches? First off, a little bit of encouragement that you're doing the right thing and hang in there, and there's no such thing as 100% in our business. And it's a mission. Rural surgery is a mission, and we appreciate you. So that being said, tell me, you've made the decision to go for a C-section. Is it an emergency or is it an elective C-section?
Almost all the time, and that is the first thing you have to filter through. Is it an emergency or is it the
one we're about to talk about? Which one is it?
The one that we're about to talk about would be an emergency.
Okay, so we have an emergency C-section. They've been laboring for how many hours?
Not precisely known. It's a Amish patient that has gone into labor by report of the paramedics, and they're 60 miles away. They reported this paramedics for at least 4 hours.
And no prior abdominal surgery?
At the time, turns out there was, but at the time they did not have that.
Okay, so what are your next steps?
Well, they're 60 miles away, so if we're planning on doing a C-section, which is what they have called for, they said, hey, you're going to have to be intervening here. She's in arrested labor. There's a lay midwife with her, and she cannot feel a presentation, and she feels like she's been in arrested labor, and she's hypotensive with systolic pressure of 90 and a diastolic pressure of 60.
So are you telling them to do anything there? They're on the phone with you? Is this a real scenario?
Yeah, this is a real scenario. They're on a cell phone that they're talking to us on.
Okay. What'd you do? Did you send a helicopter, or did they get to you?
They got to us by ground. The helicopter would have been, so this is to the south of us, which is very remote. And so they did a tiered response. The local ambulance got them, and we're getting the call from the local ambulance, and they're about 20 minutes out. Right, they've already come by the other ambulance. And they've coordinated all that through, and this is a different state. They've coordinated all that through the emergency medical services. So we get the call when our paramedics meet the EMTs in a tiered response.
Okay. So then you're getting your crash team ready for C-section. Is the patient coming straight to the OR, or are they going to stop in the ER?
No. They're going straight to the operating.
So they're going straight to the OR from the ambulance, and you're gonna give them a general endotracheal anesthetic.
So right, then there's the CRNA is going to give that, and we have the best CRNA.
And you're going to splash the prep on, and you're going to use a big wide drape, and you're going to go plan for a low transverse incision? No.
So that would be the first point of departure. I mean, general surgery is made up of people that are inherently pessimistic. I think all the ones I've been around anyway, what's the worst thing that can happen, and how can I get this person out of that? And so for that, you want proximal and distal control. At this point, you're thinking, what could this be? And the concern would be a uterine rupture. And what we'll find out later is that she had a previous DNC with a perforation.
So you decided to make a vertical
lower
midline incision.
Lower midline vertical incision, yeah.
And so you're making that. Do you take it? Just let me ask a couple of real detailed questions, because there's some of my listeners, residents, and do you, when you're doing C-sections, do you take your incision sharp all the way to the fascia?
No. First of all, I'll use cautery to go across real quick across the skin, uncut. And then we'll just grab onto the fascia, or just grab onto the subcutaneous tissue on both sides and just pull. And it typically will go right down to the midline. Okay. And then you make a small incision there with once again, with just a little bit of cautery, get your finger underneath the fascia and just zip down it.
Okay. So you open the fascia with cautery too?
Typically. If I'm going into something where they've had previous operation, then we'll dissect down. It's not, this big an urgency. In this particular case, I make a small incision where I get my finger in there and go. I mean, you can be in the abdomen in 30 seconds.
Yeah. Well, you could be. No, just kidding.
No, everybody. Yeah, I'm not special. Believe me, I'm not special. Bring my wife back.
Well, you're a bariatric surgeon that does C-sections, so you're quite the unique guy. And it sounds like you're not doing the C-sections laparoscopic or robotic either.
C-section? No. Nuts. So.
All right, sounds good. So once you're in the abdomen and you have your lower midline laparotomy, do you place any type of retractors?
Well, I pushed for this, and we've never been able to do it because they claim it costs too much. And we'll use it on other cases, but and there are times when I will just use it when I'm not supposed to be using it. I guess using a Lexus wound retractor, because I think they're great. They work really, really well, and they're easy to put in, and it's lickety split. In this particular case, that wouldn't have made a difference, because what you're confronted with as soon as you get into the abdomen is an amniotic sock that's displaced off to the left of the uterus, outside the uterus.
Okay. So what do you do next?
And this is the thing that really shocked me. And so, we've talked about the number I've done in the past. I've never seen this in the past. She's full of blood. So when you get into the abdomen, blood's all over the floor. And one of the things, so we can step back a little bit. One of the things that happened, that we have two really experienced paramedics that responded to this tiered response. And what they did is they just titrated her pressure to keeping her conscious, but not a specific number. So when she arrived, her systolic blood pressure, and she was a very, very fit woman. When she arrived, her systolic pressure, even though she could talk to you, she was confused, but she could talk to you. Her systolic pressure was high 60s, low 70s. And that, I mean, had they strived for 90, they probably would have, she would have died. Because there was no control over bleeding. So when we got in, it was boom, there's blood everywhere. You've got this amniotic sac displaced. The baby, you can see through the amniotic sac is blue. So now what do you do?
You tell me, man. This is your baby.
It's her baby. It's her and her husband's baby. And this is the thing that really shocked me and really changed the way I view C-sections. Because I'd had, a great number of them that had gone great. Let's face it, it's the only operation where you get a prize. But the issue here was, okay, the kid's dead. She's bleeding to death. I did trauma when I was a resident out at LA and at the county hospital. And, our mantra there was, save a life, damage control, go, go, go. And notice that the three things that were most important were go, go, go. So my thought was, I got to get this uterus out because she's bleeding from it. So she's got to get a C-hist. The baby's dead. So my first response is get the baby out. Now, one of my best friends who I'd gone to medical school, that's who I'm practicing with down there, who's a primary care doc, is like, well, I'm going to get the baby out. You get, and so I go down on the right side and start just taking everything really quick and clamping, trying to get down to the uterus on that side as he's getting the baby out. Baby comes out. Baby is, in fact, has no heartbeat or anything else. Gets handed off to the pediatric resuscitation team led by another good doc. And between my buddy and her, this baby lives. And therein lies the epiphany I came to with this operation is, as a general surgeon, we deal with a patient. When we're in a C-section, there are two patients. And you've got to change your mindset. But you can't and do the general surgery thing in a lot of ways. You've got to have somebody else there for that other patient. And wow. That was my epiphany. And so that's where we get to okay, should I be primarily doing this or should I be assisting it? Because what we are really is we can be lifeguards for it. It's not a hard procedure. Most of the time, this is a very simple procedure. You do it through a fan steel incision. You can't get into any, because that's the opposite of general surgery. Family medicine docs are optimistic people for the most part. A lot more fun to be around than general surgeons. And so they want to get in there to get the baby out through the little bitty, the smallest incision they can. If they get into trouble, they're like, that's a mean thing to say, but I don't
it's
think
very fair.
I don't think they realize all the things that can go wrong. And unfortunately, in general surgery, if you have a long practice, I will tell you that bad things will happen. They're not your fault, but you're going to have to deal with them. And so that mindset is different. And that's what we bring to any sort of thing in medicine. The general surgeons are the pessimistic sort of fire people of the hospital that say, okay, this is how do we get out of this?
So technically, this is a great story. I can't believe it. So first question I have is what my wife always asks me: was it a boy or a girl?
It was a boy. And the crazy thing is, so you think, okay, they lived, but they'll have all sorts of different problems. So my buddy, actually, the couple came by about 2 years after, and this was about 2 years ago. So a year and a half, I guess. Afterwards, the kid's normal.
That's crazy. So that's why, is that why he was a boy? Did you know he was a boy when you left the OR?
Yeah.
Okay.
Because I walked back to the bassinet and looked at it and go, I can't believe this. I would have killed you.
Yeah. Yeah. Because she always asks me, and I never know. And she doesn't like that.
No, I always go back. It's an amazing thing to be part of. It's like, it is truly, it's my favorite operation to do. But in this particular case, it was also the most frightening thing I've ever been.
Yeah, no kidding. I always recommend Randy's a great name for a boy or a girl, but I've never had anybody take me up on it yet.
Yeah. I don't know if David is, but Davida or something. Yeah.
Davida. So let's talk through the technical components of this, though. So, I mean, when the first you got a buddy that's standing across the table from you that's getting that baby out.
Right.
They're just opening the sack bluntly, I presume, pull the baby up, clamp the cord, take them away.
Oh yeah,
am I right about that?
Yeah, bang,
in
bang,
2
bang.
seconds.
Yeah, he had that baby out in no time, and then he packed that side. He's a really smart guy. We went to undergrad together, med school together, so it was that's the other thing. The dynamic was just boom, 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 both sides.
Yeah,
and then we had a fellowship at that time where we took full spectrum, or we took family medicine docs that had already gone through their residency and had spent a year with us. We do C-sections and endoscopy with them, so that they were going to really small settings where they were going to do that kind of same thing they did up in Canada. And that's what we mimic it, or made it like. And so I let him do the incision because he had practiced for all the laparoscopic procedures we do an open approach to get in. And so he had done a number of those open approaches. And he did a great job. I told him, you've got 4 seconds and then I'm going to take over from you if you don't, get this thing done. And he did just an absolutely fantastic job. So
okay. So when I'm thinking trauma and blood in the belly, for me it's take the C-section piece out of it. It's 5 laps. 1, 2, 3, 4, 5 in each quadrant. 20 laps go in the belly. I did not think of a blunt trauma. It's not something in the upper abdomen. Yeah. So I didn't put packs in the upper abdomen. Sure. So that's what I would do for trauma. And then I would take them out with the quadrants that I don't think the bleeding is coming from in order sequentially, or maybe give my anesthesia a little bit of time to catch up. And then as soon as we're ready, then I'll start to take them out. That way I kind of have a routine way of thinking and doing trauma. In this situation, and on the other thing is if you have a full belly full of blood, just a hand scoop to get that blood out and off before I did that. Now, in this situation, obviously, the bleeding is coming from the placenta and uterus. And so
it turns out that it's coming from a lot of it's coming from the ovarian artery on the left side.
Okay. So you said the partner took the baby out and packed the left side. You're standing on the right side and you're carrying on with pretty much immediately moving towards the C-hist. My question is, why not pack, check your own pulse, and then do you have time to do that? Or
sure. So I'm coming down. First thing I want to do is I want to get the bleeding stopped, right? So he's packed off that left side. At the time, we didn't know there's some bleeding still coming from the right side. We're packing that. At this point, the fellow had gotten in, but the case was complicated enough that you have to move to the best person in the room to do it. And so then it was just come down, and we had kind of pre-briefed this, and we talked about with induction of anesthesia, you're going to need vasoactive drugs to bump the pressure up. We're going to do what we can with augmenting pressure with fluids and what blood we do have. We have like 4 units of PAC cells and 4 units of FFP. So that was going to be going right away. That was all prepped before they got there because we had the 20-minute beforehand.
Were you calling for blood from another place too? We
were calling for a helicopter. We called when we first 20 minutes before we'd called for a helicopter. So, and the longer story is the patient turns out that everything goes fine, and then they don't want to go by helicopter. It's like, you still got to go by helicopter. So once we packed on packed on the right side, then you could start marching down with a ligature, and we had that all set up, ready to go. We had the uterus out in probably less than 5 minutes.
Okay, good. So it's going to take us
super
longer
cervical.
than 5.
Cervical.
Okay. So you take your ligature, you grab the tube. Is that where you start?
On the right side, I just took everything out because they were still working on the left side, and people were in. So I took what was available to me and just went straight down. Yeah, and got
behind the right ovary. So you're starting with the ovarian artery.
Yeah, exactly. I'm taking the ovary.
Yep.
And I'm going
and so you're going behind the infundibulal pelvic ligament, carries up artery, ovarian artery. You're taking that and then chasing down underneath the tube and the mesosalpinx on that side, and then working your way down to the uterines.
Right.
How are you thinking about the ureter at this moment?
At that point, I'm sweeping away, and I can see it quickly on the right side. What I want to do is get a couple of clamps across the uterine right away, and I'm going super cervical.
So now that you get down, like the tube and the ovary are up, and you're down sort of to the side of the uterus, and you got your uterine arteries in front of you, you're going to put clamps there, or you're going to still charge through with the ligature? Okay.
No, because I want to get the uterus out and have everything. I want to get bleeding is my first priority. I want to get the bleeding stopped.
Do you use Haney clamps, or what kind of clamps do you use?
Yeah, Haney's, yeah.
Okay, and you have the tips curved the same direction?
So they're curved up toward
and they're both curved the same direction towards the uterus?
They go in toward the uterus, and they're coming from the side. They go in toward the uterus, sort of almost at a right angle.
Mm-hmm. And then you cut between the two clamps with
I leave the two clamps down, and then I'm going to switch sides.
Okay, so just bleeding control, and then you're going to go to the other side. And the ligature that you use to take the ovary and the tube up, which ligature is it?
It was the wide jaw, one for open surgery.
The open ligature, blunt tip, big open ligature. Yeah. All right, and then you go to the other side, and now you're taking your packs out, and what do you see?
Well, you see the ovarian artery. It's so what I've done now is I've taken a 35-year-old and I've
put her in menopause.
Yeah.
Yeah. Exactly. Oh, saved her life. Depends how you look at it.
Yeah. But I could have easily saved the right ovary. But at the time, everybody's there, and I'm just doing, it's adrenaline city, and it's like, I got to get this thing out now.
Yeah. I got it. So you then have to do the same dissection, basically with the ligature, taking the ovary and the tube up, and then you get down, you put your Haney clamps on the
bleeding on the stopped, and now we stop.
Okay.
Right? So when I say that we had the uterus out in 5 minutes, we didn't have the uterus out in 5 minutes.
Bleeding controlled.
Bleeding was controlled in 5 minutes.
And then you're getting ready to divide the uterines next.
Right. So now I go and do a comprehensive search for the ureters on both sides.
Okay.
Because I am a little bit nervous. I've gone fast. I saw it on the right. I'm not sure I saw it on the left going down. I want to make sure. So now I'm going to dissect things out. The bleeding stopped. And I want to give everybody a chance to rest. I want to make sure that we've got, at that time you've lost some help too, because there's stuff going on with the kid.
Yeah. So you did not bag the ureters, I assume, in this. You find them on both sides. You've got them far away. Technically, how do you divide between the Haney clamps then, with a scissor or a scalpel?
I used a scalpel, but I put another one even higher than the two that I put low.
Okay. And then how do you throw your stitch on that? Do you use a Haney stitch, or do you just do a suture ligation?
Suture ligation.
Because the Haney stitch is twice behind.
Right.
Yeah. Okay, but you're just doing a surgeon's suture ligation, and
that's what I did.
It works fine for you.
Yeah, it works fine for me. I would tell you. So if I was doing an elective open hysterectomy, I would do the Haney stitch. Okay.
How do you super cervical hysterectomy? So is it just the one set of Haney clamps that you did, and then how do you come across the?
Opened it up anteriorly and just went around with the ligature.
So you're marching through the uterine wall with the ligature all the way around.
Right.
And then is there how do you deal with the cervix then?
You don't.
So do you have to put a stitch?
We did do a running locking stitch all the way around what we'd gone through because I was chicken. But I don't think necessarily you have to.
Okay. And your running locking stitch is the front and the back walls of the uterus together?
No,
I'm just running over the top.
Cervix is still there. So this is literally adjacent to the cervix.
Okay. In a circle.
In a circle, yeah.
It's higher than the running locking. Okay, specimens out. What other technical things do we, if you'd never done one and you have to do it by yourself the next time, what would you want someone to tell you? Any other technical pieces?
You're a general surgeon and you've never done one?
Okay. Yeah. Say I have to go do one right now and I haven't done it.
Yeah, it's unlikely that you're going to be in a situation where you have packing and a bunch of people in the way and that sort of thing. So if you're just doing a C-hyst, I would try to preserve the ovaries. So that's that would be my first thought. And then, this is another thing. All general surgery residents should be able to do a hysterectomy. I mean, at least I hope that that's still happening, but I don't get the sense that it is from talking to some of the residents. So I work with residents like for 3 days a month at a bigger hospital, and they're all very capable. And here's what we're getting off on a little bit of tangent here. I think that the training that residents get now, despite doing far fewer cases than we did in the past, is better because the attending is always there, and every case is done to an acceptable standard of somebody out in practice. When I trained, there were times when the most experienced person in the room was a fourth-year surgery resident. And so we did things, and I think, and nothing really bad happened in the residency. But I think what we were, at that point, the level of expertise in the room is not the same as it is when you have an attending. So
that's negative learning, basically.
Yeah. I don't know if it's negative learning. It's learning to do things okay, but not great, I guess. And whereas I think residents now get at least good and many times great with every case. So I think the training certainly is better for patients that we do now than it was in the past. And ultimately, we got to get away from numbers and get away from the notion that the more numbers you do, the better surgeon you are. It's the more expertise you've been around, the better surgeon you are. And so you're better off. I know a lot of the residents don't want to be in a case where the practitioner is a little bit slower than others, but they're more precise. I think maybe you ought to think about being around the precise person a little bit more.
Yeah, but there's...
There can be, you can go too far. I got it. But it's, it's just, don't let the older surgeons tell you that, I was better trained than you were because I did more cases. That's not necessarily true.
I feel you. Very, very good points. Interesting and pretty much true perspective. So I just had one more question. If you're doing these electively, you do a low transverse incision there. I just okay, that sounds good. Rather than doing a whole second how I do it, is there any like one or two things that you would say big difference between an elective versus this operation you described?
Everything. First of all, you're going to do a fan steel incision. Then you're going to go down and you're going to really, for the most part, bluntly get into the uterus. You make an incision, but you're going to extend it bluntly. It's plus minus on whether or not you develop a bladder flap. It's kind of the way the uterus lies and just how far up the bladder is. I think probably at least half the time you don't need to do a bladder flap. And I don't think you really need to push down like I was taught in the distant past. You don't need to dissect it off the lower uterine segment unless there's a reason to, and there typically is not. So, okay. And then with general surgeons, we typically do 2-layer closures. The OBGYNs do 1-layer closures. Theirs are just as good as ours. Some of the best, one of my favorite trainers was a OBGYN, and she always just did single-layer closures, and they look great. So.
When you get the baby out, so if the mother's been laboring for a while and they don't have a rupture, which would be one of the common scenarios, not this crazy situation.
It would be the most common.
Yeah, then the head can be kind of stuck. Any particular tips for getting that head out?
This is where you need to talk to your OBGYN colleagues. There's a bunch of different tricks, and one of them is having them in low lithotomy on the table. If you anticipate this sort of being a problem, and somebody can come up from below and push the head out. There's different cups and things that you can use that'll push things up so that people make different devices. And then just breaking that suction with your hand when you go down. So learning how to get kind of sweep it on up into the incision.
And you're right-handed or left-handed?
I'm right-handed.
And you stand on the...
I still stand on the right hand.
Patient's right side, and you're using your right hand to get that head out. Or are you using your left hand?
I'm typically I use my right hand. There are times when I will use my left hand.
So you just kind of have to turn your body and get your hand down there. Yeah. And then once you get that baby out, do you let them breathe on the cord for a bit before
try to for 30 to 60 seconds? Yeah.
And then you clamp the cord and then send a cord blood sample off.
Right. So you have a segment of the cord that you'll send off. It's clamped on both sides, and then
you send a segment of the cord and the cord blood. Yeah, sure. And so that's good. And then after that, then you're focused on
delivering
to make sure the pit is running, the pitocin is running, and you get good uterine tone. And if you don't, then what do you do?
There's all sorts of different maneuvers that you can use, and not so much maneuvers, but different medications. And you can talk to the anesthetist. We have anesthetists, CRNAs, so we'll talk. And that's all almost protocol driven. And we'll
make sure you have a protocol. There's a good lesson. And then uterine massage, though, to a certain extent, can help those fibers contract down and stay firm.
For the most part, the biggest thing you can do to reduce the bleeding and getting, is use ring forceps. And use it both apices of your incisions, use it top and bottom, and then look there can be other places where it's bleeding and you can use another one. So that would be one trick, is to have at least 4 or 5 ring forceps.
Do you routinely take a clean sponge and sweep the uterus?
I do, and I know that there's, talk of you not doing that, but I still do, because I'm looking
But definitely if you're having ongoing bleeding, that would be a good trick.
But I do it every I just told you I don't do it primarily anymore for the last 2 years. But I always did it. I would always get in there, and I would always do it. That was routine for me. Yeah,
fair. And so then everything, say it contracts down well. Do you always extracorporealize the uterus?
I do. Then you get into the bariatric patients. So if you've got somebody that's got a real high BMI, there's a lot of times you can't do that. That's another indication where that Alexis wound retractor needs to come out, even if the administrator doesn't want you to use it.
Yeah. And we're talking about the Alexis O wound retractor, right? The pink and orange one. That's like a circle, and it's the biggest one that they make. Very rigid. Right. I agree. I think that thing is awesome for a C-section. I was going to ask one more question. How do you close then? So now it's got good tone. You brought it out. You brought the uterus out. You close it when the uterus is up and out then?
It depends. Thin gal, yes. Bigger gal, maybe not.
Yeah. So now you're ready to close on the skinny lady. And what suture do you use to close the uterus?
Vicryl.
Okay. And what do you know? It's on a taper needle?
It's on a non-cutting needle,
yeah. And a big needle. And then your first stitch, you got your ring forceps there? You leave that on when you throw your first stitch?
Yeah, they do make ring forceps that have a little cut in them, so that in case you go through one of the rings, you can get it out. And
that's interesting.
I've invariably had those. I mean, some parts of my career they're around, some parts they're not. That is a frustrating thing if you go through it. It doesn't happen very often, but if it did go through it, so you
go behind the ring forceps, and you out to in.
Yep.
In to out, and you tie your knot out lateral to where the corner is,
and then put it and tag that.
And you tag that, and then that's tagging the tail, but then you run with the rest of it?
Yeah.
Okay. And is it just a baseball over-under stitch the rest of the way, or
that's
how
what
do you do your one layer? So versus 2-layer closure?
Well, so there is no difference. If you look at the literature, there's no difference in the complications relative to the closure that you use. So this is more an opinion than it is a factually based statement that I'm going to make. I am uncomfortable just using a single layer closure, even though I know it's just as good as scientifically, it's just as good as a 2-layer closure. So what I'll do is I'll do a running locking suture where I snug things up with the first layer, and then I would do just a running suture where I bring over there's 3 muscle coats there, and you try to bring over that last muscle coat.
Okay, yeah, and that's all I want to know is like how you do it. And I think a lot of things that's the problem is there isn't necessarily a right answer, so it doesn't end up being an absite question. And then I know for me, when I first came out, it's like, okay, I had this book where I wrote down when I watched different attendings do different things. And so I know there's more than one way to do it, but what do I really want to do? And then I'm calling people, for these finer details. And that's why I'm trying to kind of focus on it, in case the listener, if it's helpful to them. So thank you. And then next question, do you close peritoneum?
So I don't think there's any strength in it. Most OBGYNs do not do that. Having been on a great number of repeat C-sections, being able to have the anatomy still intact so you know where you're going and what you're getting into as you go down in layers, and then also doing it with learners all the time. Long-winded explanation. So the answer is yes, I do.
Usually, yes. I guess before you close the peritoneum, do you pull the omentum down and lay it over the uterus?
As much as you can.
Okay, and then you close the peritoneum with like a 3/0 vicryl?
Yeah, exactly.
Okay. I think I did a bunch of C-sections with and without OBGYN, mostly with, and most of them did close the peritoneum that I worked with.
They don't around here.
Okay. I saw one complication in residency where there was actually either incompletely closed or the top part of that peritoneal closure tore through. And there was actually a small bowel herniation with bowel obstruction and dead intestine about 2-3 days postpartum into that preperitoneal space. So it's hard because they're on exam, there's no hernia, but then of course you can see it on the CT scan and she's in severe pain. And that was dead bowel, had to do a resection through the phalansteal and everything. And that just kind of anecdotally made me wonder, what do we think about closing this layer? Because theoretically, the peritoneum doesn't heal that way. It heals by whatever stem cells in the peritoneum, regenerating. Okay. And then you close the fascia with what?
Double-stranded OPDS.
Okay. And then there's some data about like the depth of fascia or the depth of the sub-Q and whether you should put a sub-Q stitch or not. If it's greater than 2 centimeters, you could put like a 3/0 vicryl, reapproximate the sub-Q. Did you do it that way or any other tricks there?
Yeah, we'll go across what essentially is scarpas almost, that middle layer. And
if they have nothing there, then you don't close it.
Typically, because we use a running subcuticular suture of 4/0 monocryl, so we will we'll still bring it together because you don't get a whole lot of strength in your closure with just a running 4/0 monocryl.
So pretty much exclusively. All right. And then you put glue over the top of that? Steries?
Typically glue.
Glue. And then a la casa, I guess.
And then, exactly. So
that's good.
Then watch them. And as a general surgeon, even though you've just been the proceduralist in this, you own that patient now too for their operation. So you see them every day when they're in the hospital, and then you see them post procedure. I always see them twice, or would see them twice.
Okay. So, and that would be like what, 2 weeks, 6 weeks kind of thing?
Exactly.
Okay. Very good. Well, thank you so much for that deep dive. That was a lot of fun for me. I don't know if it was for anybody else, but that's okay. Not too worried about it.
Yeah.
We got to keep moving here. The next segment of the show is called the Financial Corner. I was wondering if you had a money tip for our listener.
Don't get divorced.
That's good. That's a good one. That's a very good one. You hear often one house, one spouse. You've moved around and had a divorce, and you're coming at us with the biggest financial tip that your takeaway from this is try not to get divorced. But it's easy to say. How does someone not get divorced?
Ooh.
On the Rural American Surgeon podcast. Today we're talking about how to not get divorced.
Oh, wow. Yeah, it's an interesting question. And obviously I've pondered it. I think people make the decision to get married based upon age and not maturity. Some people, and we've had friends where their kids have gotten married at 18 and have great marriages. We've had friends, and I've seen it in my own life, where you can be in your 20s and mid-20s and get married, and you're just not mature enough to be married. So I have an accurate assessment of both your and your potential spouse's maturity. And if that maturity is sufficient that you can take on And even if you don't want to have children, if quote unquote there was a mistake and you had children, that you could take care of children, I think that's a litmus test. And if you're somebody that can't subvert their own interests to the interests of another that you love, that's not going to work out well, no matter what. But if you can subvert your interests, so if you know, for us, we wanted to have kids, so it was that wasn't an issue. So we met that maturity mark. We did not meet the maturity mark of saying, okay, what's attracting us to each other? It was physicality. It wasn't, you know, she's a rich gal from New York City. I mean, what am I doing with her? I mean, and that all came into play. And then she's a Christian, but there's a wide variety of Christians, and some Christians can accommodate behaviors that other Christians can't. And so you got to have a similarity there too.
So I wish I could say, be a Christian and you won't have a divorce.
That's not true.
But it turns out that right now, the rate of divorce is similar between professing Christians and the general population, still sitting around half.
Mm-hmm.
Now, I attend a church called Apostolic Christian Church of America. It's kind of an interesting church. It's what a church I was raised in. We have a 3% divorce rate in my church.
Did you have covenant marriage then?
No, we don't have that.
Okay.
But I think there's definitely social pressure not to get divorced. That you know, you say that to people, and there will be others that will say, well, maybe there's these marriages that shouldn't be stuck together, and they're you know, people will go the wrong direction with it. The reality is, marriages in my church are actually working, and I know so many people with such good marriages in my church, and I think it actually is like one of the biggest things with my particular church, which is a small denomination, that I think really it says something really positive. But people are sincerely trying to, you know, there's a triangle, and the idea being that you have a husband and a wife, and they're the base of the triangle. And if they can both get closer to God, they get closer together as they move up in the triangle. I think that that's being done. And I want to propose that to people, but you know, you have to look at the data if you're an objective person and say it's not just about being a nominal Christian. But I do think that first off, you have two people that just really don't want to get divorced, and they really have, like you said, the maturity to understand what that means when they make the commitment in front of all their friends and family, saying, I'm going to stay with you forever. Mm-hmm. And then knowing what that means to go through. And then the question though is, you know, I just had my 9-year anniversary. Mm-hmm. And, you know, my grandpa I just took him to Hawaii, and I think he's like 72 years into marriage, something like that. It's crazy. Yeah. I mean, he's 95. So it's something along those lines. But, you know, you ask him, and how long has he been married? Oh, 2 or 3 good years, you know. And you want to have a good attitude. But now I've been married 9 years. It's not always been great. There's been some bad overall years. We've been, you know, but we have to have that not long-term focus and that never quit attitude. That's what's helped us. What I was kind of wondering if you would say is things like having a counselor or going on marriage retreats, or, you know, anything like that. But for us, it means taking a barometer of where you're at in the relationship, and when it's not good, doing something to fix it actively. Mm-hmm. And people say things like never go to bed angry. I've gone to bed angry, and I'm still married. You know, and that, maybe not having that fight is better. I don't know, but and I'm definitely not the marriage expert. Okay, I'm asking this question just like I'm asking all the surgery questions, mm-hmm. which is as a learner, you know. Mm-hmm. But since you brought it up, mm-hmm. We want to take steps to try and avoid it. And I guess if you were asking me, I would say being sincere and open, good communication. working on your marriage, considering it not to just be something that's serving you, but considering it one of your most valuable assets that you want to kind of continue and maintain working together. And then also, if keeping God in the center of your relationship. It's if you, sometimes I'll say to my wife, and we've kind of played this off to each other, is Jesus is sitting in the room. Am I going to say, how am I going to talk? That makes it a lot easier for me to have those conversations. Now, do I always live up to it? No, but those are my thoughts. What do you think about that?
Yeah, it's so if I had my druthers, I wanted to be a pastor. I did not want to be a doctor. That was my first. That would be my if I could do anything. But I have a horrible temper, and I constantly and it's not. Most people would say, "Oh, he's such a he seems so blah, da, 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 da." But inside my mind, I have this horrible temper, and so I'm constantly fighting that. I would say that the thing that makes this marriage work where the other one didn't is this one is built. You're right, around God. The other one was built around God as our own faith journey was at that time, and both of us were in the middle of medical school. We're stressed out, so that had something to do with how that didn't work out. And then we came from two entirely different upbringings. Whereas this one is, she's a small town girl. Her father and my father are very similar people. Her mom and my mom, not quite as similar, but still somewhat similar. If you were doing arranged marriage, this is the one that would have been arranged for both of us. And I think that, and then I can talk about that. My Indian friends with their arranged marriages, those all work. Mm-hmm. So it's like
somebody's being objective on the outside looking at it.
Right.
So arrange your own marriage. Next segment of the show is called Classic Rural Surgery Stories. Mm-hmm. And this would be a story that your urban counterpart just couldn't believe, but you just told us one. Do you have another canned story that you might want to share with the listener?
So I'm out walking the dog, and two houses down from us, and we live in a historic neighborhood. Two houses down from us is this, what I think is the radio, and it's this opera singer, and it just sounds fantastic. And I just, that's really cool. So I asked that neighbor. I said, "Hey, what were you listening to?" "Oh, it's a Romanian student." That is, and we have a college half a block away from us. That's going to Central College. Who's also an opera singer. He's a music major. And so, that's cool. Well, it turns out that he's been having troubles, and he gets hoarse once in a while and that sort of thing. And at that point, I was doing a lot of Nissen fundaplications and stuff. And so and obviously he's not on our insurance, he's not in an American insurance event. So the hospital, we work him up. He's got reflux, pretty bad reflux. He needs a Nissen fundaplication. This can only happen in a small town. So you go talk to the administrator. The administrator says, "Sure, we'll put it in the paper, and you can go ahead and operate on the guy." So we operate on this guy, who then can, preserves his voice and that sort of thing. And that only happens because you're in a small town and you're walking by with your dog, and you think it's the radio, and it's a guy that is actually, and he's became a prominent opera singer over in Romania. We went back, and I think he's a cultural minister now. This is probably 20 years ago.
Yeah. Wow. What a fantastic connection with you can work with your administrator in a small town. I have found that to be true myself. So thank you for sharing that story. Last segment of the show is resources for the busy rural surgeon. Do you have one great resource that every rural surgeon should have?
Friends. So the biggest thing is maintaining contacts in different specialties, especially during COVID. That worked out great. And so that was the thing that worked out the best. So practicing in two different places, one of them being large and one of them being small. So having the ability to call the big place when you can't take care of it, it's a small place, and arrange transfer through friendship is critical. And then being able to go, don't isolate yourself. If you're a rural surgeon, you need to go down and go to morbidity and mortality conferences. If you have a complication, take your complication. I mean, I can't imagine that anybody wouldn't want you to. And then reach out to residencies and offer if somebody wants to do a month with you, or even medical students, that are looking to go into surgery take those on. I think those are the best.
I love it. That is the most common thing that people say on the show is actually other people are the best resource. I didn't know where that would go when I started the program. I thought it might be, books or selected readings or conferences, but definitely the personal, somebody you can call is the number one thing. So thanks for sharing that yet again. Dr. Kermode, It's been my pleasure and honor to have you on. Thank you so much for joining us. The last thing I did want to talk about was you have been a guest multiple times on another podcast, the Really Rural Surgery podcast. Am I saying that right?
Correct.
And that's with you and Dr. Batchelor, who is a generalist in Canada, but does some surgical procedures. Am I correct on that?
So they have a program where they go through family medicine residency, and then they spend an additional year doing procedural medicine. So they're 10 times more isolated than we are geographically. And so where they practice, there typically is not, many of them practice, there typically is not specialty coverage. But the way they go about doing we talked about, being programmatic, not just, doing custom fit all the time. The way they practice in these rural settings is they'll have OBGYNs and general surgeons that they're linked with that they can call. That's that relationship part. And then they'll come typically about every 6 weeks, as I understand it, and practice and go through different procedures with those ESS physicians, enhanced surgical skills. So, and I've met a lot of them, and they're all great people.
That podcast was started late 2014, and then he hasn't recorded anything for a while?
We're doing another one. It's not, it doesn't come out at fixed intervals. We tend to do probably 3 or 4. Brett tends to do 3 or 4 in a year. At one point we were doing, more than that. Well,
I appreciate what you have done in just sharing your experience, both with your trainees that you've continued to be involved with the shows that you've been involved with, obviously with each individual one-on-one patient. So you should feel very accomplished and proud of the body of work that you've done, because it seriously is, you sit back and you think about it from an objective perspective, from your wheelchair looking back, and you've done great work. So I really appreciate you taking the time to spend with us this morning, and come back anytime.
Oh, no problem. And then I'm also involved with the Rural Medical Training Collaborative. So that's another really good organization here in the States.
Okay. So you can check that out. We'll throw a link in the show notes. Thank you for listening to this episode of the Rural American Surgeon Podcast. Please don't hesitate to share this with anyone that has an interest in rural surgery. If you don't mind giving us a rating or review, like or subscribe, join us on Facebook, interact with us. We appreciate you being here, and we'll see you on the next episode.